So, today's episode of PHEMcast, I'm really excited to be doing a joint podcast with our friends over at PHEMcast. And this topic is definitely one that I do not have any experience in. So we've roped these guys in to go through the considerations for jungle medicine. I'm going to let them introduce themselves.
So my name's Sean Hudson. Primarily, I'm a GP in the north of England, but I've done a lot of expeditions in the jungle environment. And for the last 4 or 5 years, I've done med cover for the military for a number of exercises twice a year. So I think I've been there 6 times to Brunei and to Belize.
Okay, my name's Matthew Boulter. Likewise, I'm a GP, but I'm a GP in the country, right down in southwest of England in West Cornwall. But in a similar vein, I'm also a military GP, and I have been for over 30 years now. And again, in a similar vein, over the last sort of 10 or 12 years, I've covered major jungle exercises in Borneo for the military, so once, twice a year, and have developed quite a bit of a niche, nerdy expertise in all things jungle medical.
And my name's Eoin Walker. I'm a critical care paramedic and a paramedic of 20 years. And I first started my jungle experience in 2006 and then 2007 for a number of expeditions. And then I've been in Costa Rica teaching the World Extreme Medicine jungle course since 2012.
Fab, thank you. So clearly there's a huge amount of expertise around the virtual table. First of all, guys, can you just give us an idea about what it's like in the jungle and why that presents a challenge when we're looking after patients and people who are there?
Hot and hot.
I think to some degree.
Go on, Matt.
I'll say to some degree it depends. Heat and humidity are significant factors. So it just makes living and existing yourself, just as a medic, looking after yourself is hard work, and just living in that environment, let alone having to try and do a professional job as a clinician. But one of the significant factors, it depends how remote you are, but if you're doing proper remote jungle medicine where you may be days and days walk from a road, your CASEVAC time and your CASEVAC implications are significant. It is not an easy thing to CASEVAC someone out of a jungle. And you're pretty helicopter reliant, and that isn't as, oh great, here comes a helicopter, easy as it sounds. It's fraught with difficulty, and the CASEVAC is a very careful card to play, because you can create more dramas than you'd originally intended by sitting on someone for maybe longer. So I think experience counts in that environment, and certainly what colleagues have seen, but the less experienced clinicians in the jungle may panic too early and CASEVAC too early for something that perhaps didn't need it. And the CASEVAC burden is significant if you're very remote.
Okay, so Sean, when we're thinking about the sorts of problems you might face when you're looking after people in the jungle, how would you categorise them and break them down, and then we'll explore each one?
So I think as you practice medicine in any country, you've got your standard primary healthcare and your standard trauma. But in addition to that, you've got some quite significant environmental issues, whether that's related to heat injuries. And then that, of course, is made worse by the fact that it's a horribly humid environment. And then you've got the fauna and flora. And on top of that, you've got all the endemic diseases. It's probably the most complex environment, I'd suggest, in which to function as a medical professional. It's challenging not just from a medical perspective, but it's pretty challenging as well from just surviving and managing and processing yourself, never mind then delivering a professional job when you're trying to look after other people just on a day-to-day basis. So I think we use it certainly in the military as our sort of primary testing ground. If you can function in that environment either as a soldier or as a medic, you're pretty much competent to go to most environments and be reasonably comfortable.
Okay, so let's think about the jungle-borne diseases then. Eoin, do you want to go through the sorts of things that you might see?
Absolutely. Thanks, Claire. Yeah. So it's prudent in any jungle environment, I think, to understand the prevailing epidemiology of disease. And so in the majority of cases, mosquitoes will play a large part. So it's prudent to know whether it's a malaria ridden or born area, and then it's prudent to then take prophylaxis if you are going into a malaria area. Fortunately, in the Costa Rican jungle, malaria isn't prevalent anymore, but there is other mosquito-borne diseases such as dengue and Zika. But so you really have to have a good idea of what the prevalent disease is, but it's also not necessarily just about the mosquitoes. So as Sean alluded to, and Matt, it's really around the prevalence of common things occur commonly, such as heat illness. One of the biggest sort of testing grounds, as Sean was saying, is that actually there's prevailing humidity in these environments, and it's not direct sunlight, but it's the humidity that really catches people out. So in a sort of an unacclimatized candidate or participant to the jungle environment, what the most common pathology we see is around heat illness, and that could be heat exhaustion all the way through the spectrum. So it's understanding that common things occur commonly, but then you've got the bites, the stings, you've got the snakes, the spiders, you have just like Sean was saying, the forest and the fauna. So you have the flora, the environment itself. You can have some really difficult terrain just to navigate through, which might have in itself plants which might cut the skin quite easily, and so it's prudent just to be situationally aware. But the main categories would be the fauna, which is the animal life, the flora, which is the plant life, and then the environment itself, which is the humidity. And to mitigate all three, or have a good idea of all three, so you've got mitigation strategies.
I've got to say, Eoin,
I think you're right. And to some degree, you can have a perfect storm where these things can link together. So if it's hot and sweaty and you're really struggling with exerting yourself in that environment, if you then get a fever on top of that, physiologically you start to crumble quite quickly. So I think, Claire, you were saying about, mosquito-borne disease. If you get a febrile illness that's insect-borne or whatever borne, it's highly likely to put you out of daily physical activity, and you may well be a cardiac candidate. And it's clearly pretty difficult to know what exactly that febrile illness is, if it's a tropical febrile illness. But if you're doing some sort of trekking or movement type activity, that individual is be highly unlikely to carry on. It's just too much physiological overload when you're trying to cope with the heat, the humidity, and physical activity all at once.
I think
Okay, so I think it would be really good to go on.
I was going to say, I think it's interesting that we always get, or people often get concerned about the endemic diseases that they're going to come across, but your diagnostic capabilities is so poor for the majority of these expeditions that your differential diagnosis is really quite small, and you treat the things that are most commonly present as a fever. I don't see a lot of issues on expeditions with the endemic disease in the jungle. Predominantly, what we see is a general sort of degradation of the human anatomy. The person physiologically and anatomically just starts to decay. It's it's a hot, humid, dirty, strenuous environment to be in, and then and the other thing is the impact of heat and humidity on the physiology. So, I'm sure Matt will say the same, but the majority of things that we have to deal with on protracted military exercises are heat-related illness and just sort of general body deterioration, and then the simple infections that you get as the result of that. Would you agree, Matt?
I would. I think. I guess we should probably discuss it, because we keep circling around it, and it does predominate. You can have humidities regularly in a jungle day in the high 90s, temperatures in the 30s. There is very, very little air movement in the jungle canopy. So it's just hot and sticky. There's little solar radiation directly, as Eoin said, because you're covered. But if you do go out into a clearing, boy, you know about it. But it's that radiant heat and ambient heat in the environment, it's very difficult to sweat, and your clothes become very soaked very quickly. Your clothes start to rot on you, and everyone has a jungle smell after about 12 hours that just doesn't go away, and kit will rot on you. The heat is all encompassing. We try and acclimatise the military guys, and we're doing a lot of work on looking at acclimatization with the Institute of Naval Medicine and doing various regimes to improve that. And can you make it more quick, more rapid, rather accelerated acclimatization? But when you're in country, you need to acclimatize in the climate you're in the microclimate you're in. So if you do go to Borneo and you're at beach level for a while, you can get nice and hot. But it's a very different microclimate for when you then deploy up under the tree canopy, where it's hot. You have to sort of start your acclimatization again. And to fully acclimatize, you're looking at a couple of weeks really. And in many environments, depending on what you're doing, unless you're on a very protracted task or expedition or trekking thing, you're just not going to have time to acclimatize to that microclimate. So it's highly likely that clinicians looking after that body of people are going to see exertional heat illness, which is the sort of the catch-all term for piling in when you're walking around the jungle and it's really hot. So EHI is the buzzword that sort of covers it all, really, that whole spectrum from feeling a bit hot and sweaty through heat stroke to sort of single figure GCS, and it can happen really quite quickly, and it's we see it a lot.
Okay, so can I get you to describe that in a bit more detail then? So what is the spectrum, and how would a patient or a person initially kind of start to show warning signs? What are you looking out for in the group of people you're responsible for in terms of seeing the early signs? And then is there anything you can do at that point to stop it getting any worse?
Go on, Matt.
I think the early signs, if you're doing some physical, it's in some ways it's quite like hypothermia in a bizarre way. At the other end, it sort of presents very similarly. People perhaps will, if you are trekking, walking, will be lagging at the back and struggling and stumbling because they are not coping with the physical exertion in the heat. Things can come on actually really quite quickly if people, certainly some of the military guys, are under quite pressure to keep up with the course. So there's a bit of an adrenaline rush keeps them going. And it's not at all uncommon for them to stop for a brief pause or a rest, and then they just suddenly pile in because the adrenaline sort of lowers. So it's going to be stumbling, confusion, unsteadiness. Incontinence is quite common, both urinary and fecal, and particularly urinary. People just find they wet themselves because they're starting to have sort of neurological sequelae. We are keen to do, certainly in the military environment, if we can. It's difficult, but we'd really like to look at some sort of point of collapse blood testing to help further validate what is going on physiologically. Clearly, it's multifactorial, but it will be really good to know what is going on. But when you certainly get in that in an EHI patient, exertional illness, it's an exertional heat injury or heat illness patient, you develop a hypermetabolic state, and if you do a blood glucose on someone, it's down at 2 or so, even though they've eaten well that day, you just become hypermetabolic and consume all your circulating glucose, so that can have a factor as well. Hydration can be a part. There's often a lot, the jungle tends to be a wet place, so access to water is quite common, and we all sweat differently, and we release different amounts of salt in our sweat. But dehydration certainly can have an element too, but it's definitely multifactorial. And it presents with this stumbling, confused, dazed, difficult to answer questions, lagging behind the group, fall over, collapse, wet themselves, incontinence, start to have seizures, lose consciousness. And you can have people at quite significant single figure GCSs really that are fitting on you, and you may be several hours away from, or an hour or two away from a hospital by helicopter, if the helicopter can fly, and they can't always because of the sort of some of the thermal injury issues around flying over a wet jungle. So it's quite scary when you see someone collapse in that state, about how you're going to manage them when you've probably, it's not the finish line of the London Marathon, when you've got ice baths and fans, you've probably got literally the kit on your back. So managing that patient becomes, really quite challenging.
So can I just come in there, Matt? So I agree that.
Great, thank you. And so what? Yeah, please do.
Sorry, I would say the analogy with hypothermia is interesting, because I'd agree completely that they present like a moderately hypothermic casualty, in that they've got that sort of stumbles, fumbles, mumbles, and grumbles, but they go so much more rapidly from that state to really significantly unwell, sudden deterioration, and that's really rapid. So guys will come in and their venous return will reduce, and they'll collapse, and they fit, and their fits tend to be really short-lived. They tend to be probably as the result of hypoxia, so poor venous return, poor reduced blood volume, hypoxic episode, fit, elevate their legs, and they tend to regain consciousness again and stop fitting. I think the recovery as well from hypothermic, so exertional heat injury, can be much quicker. So, I think it's rare. I can't remember, in fact, the last time I saw somebody who was really unwell. And I've seen a lot of people collapse with heat injury and fit. But it's been a long time since I've seen somebody who hasn't recovered with really simple, cooling intervention. And it doesn't need to be aggressive or complex. It just, we've nailed it down to a £1.50 plant spray from the local shop, and a fan, which is a piece of plastic. And generally, that will reduce somebody's core temperature really quite rapidly. So it doesn't need to be, a gurney with ice and rapid cooling. You strip them naked, spray them, and fan them. You can find that that's almost as much as you need. Would you agree?
Yeah, I wouldn't. We have this sort of like quadruple SF, so SSSF. So stop what they're doing, put them in the shade, strip them down, soak them, and then fan them. And the people who are doing the fanning should be exerting themselves almost as much as the casualty was. You fan and fan and fan, all of you as a team around that person, lying head downhill. And if you do that well enough, it's simple and it's quite old school, but it's all you've got. I've yet to know a casualty that we've not significantly enough to improve to get them back on their feet. It's basic, but it's all you've got. And to date, in the dozens of casualties I've seen, we've managed to get them all back with aggressive fanning. And as Sean says, you just spray them and spray them and spray them and soak them. People do start putting IV lines in, but to be honest, we never got to that point. We've managed to get them around sooner. And these are people who are sort of, fitting unconscious, eyes rolling in the head, really, doubly incontinent in a bad way. I guess we should rewind a bit and say prevention is better. I think the original question, Claire, was, how can you spot these people? And some people, it would seem, are more susceptible than others. So certainly in the military, we have return attendees who collapsed, thought to be a heat illness, not sure, come back, and some people just can't cope as well in that environment. There's a genetic thing there, and I guess it's a bit like AMS. Some people do, some people don't. Complex area, way beyond my level of genetic understanding, but there is a genetic element, I'm sure. Physical fitness will help. If you're more physically robust, you will be less likely to go under because you can cope with the exertional side of the illness. But I think one of the things that people often talk about is taking temperatures. So we've done a lot of work on temperature taking, and people talk about core temperature. Actually, to measure a core temperature, it's a proper deep, sort of 10 centimeter long rectal thermometer to measure a core temperature properly. And in essence, no one is going to take that into the jungle unless you're doing proper scientific research. So people use sublingual thermometers, sort of the baby armpit thermometers, rectally, but it's not rectally. It's probably more like anally, as an attempt to replicate core temperature. But I think it's not actually. You're more likely measuring anal temperature. But personally, I just use tympanic. You need a tympanometer that's quite robust in that environment. But it's quite routine. So we've done a whole lot of work looking at people who haven't collapsed or are fitting well and exerting themselves. And if you just go around and take 50 people and take all their temperatures, you'll have people there with temperatures over 40 who are stood there looking at you saying, "What's your problem?" So we find testing temperature not surprisingly, I think, not a very reliable indicator of is someone going to go down with heat illness. I think respiratory rate is a far more early sign. People have respiratory rates, pumping out. So when they collapse, we have a set regime where we measure a simple set of OBS, pulse, respiratory rate, conscious level, and temperature. And we've got a mechanism now. In fact, it got published in the Journal of the RMC of how we then assess that. So you measure them at the point of collapse, initiate your treatment, and then measure them again at the 30-minute point. And it's scored in a bit like a GCS, but in a more simple way. And if your score has improved significantly, you're deemed fit to carry on at risk. But if you've not significantly improved on your numbers by the 30-minute point, we tend to say, enough's enough. If we push this person anymore, this is going to get worse and more serious. But I think, but key message: temperature is a poor indicator of degree of severity of EHI.
What it's quite good at, though, is it gives you a trend. So it's certainly, I wouldn't say let's not do it, because I'd agree entirely. As an absolute reading, it's virtually useless. But what it does do is it tells you, what's happening when we're cooling somebody. Is their core temperature coming down and how rapidly? And as long as you're measuring the temperature in the same way, you're getting an idea of how quickly you're cooling them. So I still think it's valuable
exactly.
tool.
It's a good indicator of recovery.
However you do it doesn't really matter.
Yeah.
The beach physiology that you were doing with the Institute of Naval Medicine in Borneo, I think that was fascinating, because we always used to think, the old school was that you had heat exhaustion and heat stroke, and they were a spectrum, and it was defined by what your core temperature was. But I think when Matt and I&M were doing the research piece on core temperatures with swallowable thermometers, and then the cooling impact because we used to run the guys down the beach, and then they would get in the sea, and they would theoretically cool down, they'd get out, and then they'd run on again. And you were discovering that guys were standing up and functioning perfectly normally with core temperatures off the scale, and they're actually getting into the sea and theoretically cooling down, but all they were doing was telling their peripheral thermoreceptors that, that feels nice and cool, but not actually making any difference to their core temperature. Is that right?
Yeah, cold water immersion is, and there are jungle rivers, and it is an option. And if you've got one nearby, it's not a bad idea, but clearly you need to do it with care to protect the airway and all that sort of thing. For obvious reason, it's a good way of cooling someone down, but you probably need several people holding that person about, particularly if they're fitting and thrashing and semi-compliant. So we do it sometimes, but it's sod's law. There's never a river there when you want one.
My daughter did explain to me last year, it's all physics, Dad, and it's down to latent heat. So you need to change your H2O to a different state, and the closer you are to that state, then the more energy it's required. So theoretically, I think that's what she said. I wasn't really listening. So if you got droplets, it's going to go into a gas form much quicker. And if we put somebody into cold water or cool water, we're not going to change its state. So we were looking after discussion with I&M, we were looking at using some sort of slush bath in our jungle camp. So we have a couple of fixed locations that we tend to see our casualties. So we were looking at taking out sort of slush in some sort of cooling box and use that for the guys who are significantly unwell. But the spray works so well that, to be honest, they'd have to be really sick for me to go down that route.
We've also tried these things that you may have seen called care vests, CAER, and there may be other ones available, which is like a an anterior waistcoat, looks like a bulletproof vest, but you just wear it across your torso. And if you pour fluid into it, it sets up a chemical reaction. The thing becomes a cooling vest, and it has sort of extension pieces down into the groin and up around the neck. And it's been used very successfully, I think, in more benign environments. London Marathon, I know that they've used it there and various sort of sports events. And it really does assist with the cooling, which is great. But by necessity, they are quite big and bulky, and it means you've got to carry these things around with you. And if you as the medic are carrying your kit on your back, you've got to be quite limited or get other people to carry these things around. And we've certainly found that, and we've used them in the UK, and you crack one of these things off and they'll stay cold for 2, 3, 4 hours and they'll still be cold to the touch. Whereas you do them in that environment, after 30, 40 minutes, they're done. They've done their job. I'm not saying they don't work, but if you've got them, great. So if you're in a fixed location, you can get those sort of slush jackets or whatever you've got. It will help. But sod's law, the casualty will collapse at the most distant point from where your med kit is, and away you go.
Yeah, I was just thinking those like those wine cooling jackets. That's the kind of thing, isn't it?
Yeah,
but
exactly, yeah.
They do not cool my wine sufficiently, so I can see why it wouldn't work on a person.
You're so metropolitan, honestly.
Tricky. There's a reason I'm just asking the questions, gentlemen.
I only use it on my champagne these days. So.
Okay. So I think that is a really nice summary of the kind of heat issues and how you would manage them. So am I right in thinking then that actually you don't really kind of worry too much about whether or not it could be a jungle-borne disease that gives you a fever or heat illness, because the management is the same?
I was going to say we're pretty empirical with, you have an idea of what the endemic diseases or the common endemic diseases are in the jungle environment that you're going to go to, and there are numerous places that you can look that up. I mean, whether that's Travax or Nathnak, you can get an understanding of the diseases before you go. And then there are some rapid diagnostic test kits which are available for certain diseases, and they're pretty good, but they're few and far between. And so you're limited, and you're really going back to your clinical skills, which most of us don't tend to practice because we're so reliant on investigations and investigations. So I tend to have a list of what are the most common endemic diseases that I'm going to come across that will cause a fever and make people unwell. What are the incubation periods for those, and what are the principal presenting clinical features that they might have that would point you towards it just being right, that is dengue, or that is malaria, or that's chikungunya, or whatever the endemic diseases might be. And then I tend not to keep anybody. If anyone is so significantly unwell with an endemic disease, the chances are I'm going to treat them and then try and move them on to somewhere else where I can actually get a better picture of what exactly is going on with them. And so you're probably, it doesn't matter whether you're on an expedition or whether you're working in a remote clinic, you treat the things that you think are going to kill the individual the quickest, which are the most likely things that they have, and you work down that list. So you might be giving IV antibiotics plus or minus artemisinin plus or minus quinine, or whatever you feel is the most appropriate treatment. So it is a bit of a broader brush, to be honest, when you're working in these remote environments, especially in the jungle. Thanks,
Sean. And as an associated question, what about the diarrhea and vomiting type illnesses? Presumably, the likelihood of getting one of those while you're in these environments is a bit higher than in normal life. Do you come across those sorts of conditions that are going to need you to be rehydrating the casualties?
Yeah, so I was just going to say, yeah, absolutely. So one of the things you have to bear in mind is that traveller's diarrhea is common. So I think in these environments, you've almost got to anticipate that you will have a spell of diarrhea. And it becomes a lot more relevant if you're taking medication, because you're not going to be necessarily absorbing that medication properly. And preferentially, you're going to also be quite dehydrated in a hot environment. So it does put you at a physiological disadvantage, and it can cause a lot of lethargy. a lot of acute lethargy, and also just from a sort of a social perspective, people aren't going to want to come forward and tell you they've got diarrhea, especially if it's not self-limiting, which is interesting, because if people aren't necessarily coming forward and they are taking medication, then it really is reliant on you being an anthropologist. So you've got to watch these people, you've got to watch the group, because as Matt was saying, people can actually quite quickly become subject to heat illness, and it can come on very quickly. And interestingly, from my experience, from some of the most fit members in the group, if they start to become acutely lethargic and or migrate to the back of the group, that's the point, that's the time to intervene. And so there's a lack of absorption of both food and or medication. They're going to be dehydrated from the weather already, and so what we say is if it's not self-limiting to 24 hours, that's probably the time to start looking at medication, antidiarrheals, starting to take electrolytes, so oral rehydration salts, and start to supplement, so you're ahead of the curve, especially if you're doing a lot of acute exercise. And it also lends itself to this situation awareness, which I'm sure we'll get onto shortly.
I think it's a slight misconception, to be honest, that you see loads of diarrhea and vomiting in a jungle environment. So if you're in contact with the local population, of course, any fecal oral disease is going to spread. And if you're not following sort of your standard public health advice, you'll catch something. But actually, if you're on an expedition or an exercise and you're a closed group and you are in the jungle, diarrhea and vomiting is actually really uncommon, because you've got to pick up the endemic disease, and it's fecal oral, so you don't actually come across it that often. Mm-hmm. But if you're on a short trip, or you're in contact with local population, you will come across it. You tend to treat it more aggressively earlier, just simply because you don't want somebody, they can't function. If they're stopping 15 times a day or 20 times a day to go to the toilet, they can't function and they're getting dehydrated, and they run the risk of exertional heat injury. So I would tend to be slightly more aggressive with these individuals and assume, most travellers' diarrheas, 85% of them are bacterial anyway. So I tend to go early with antibiotics, unless we were able to be in a camp and I could isolate them and they could be near a toilet. So I don't actually see travellers' diarrhea actually that often, except when we are in contact with the local population.
I think the other thing to say is, again, prevention is better than cure, and think about your food sources, food storage, and water sourcing, which needs whatever food you're going to survive on needs some careful thinking, and, washing your cooking utensils and cutlery and that sort of thing, because it's a dirty environment and bugs will grow fast. So it's basics, but if you've got a group who are jungle naive, it's something that perhaps, as the public health expert in the room, as the only clinician on the expedition, that's going to fall to you to make sure that those simple things are being done well, and people aren't cutting corners and not washing up properly of whatever the cooking utensils are, and drinking appropriately purified water with whatever mechanisms you've got to clean your water. Otherwise, you're going to see a lot more of it. And certainly in the military environment, we go to huge lengths to protect our food sources and purify water.
Yeah, thanks, Matt. That's an excellent point. I guess we're talking about different people having different experiences in terms of how much they can contribute to the advanced planning of the expedition, and that came up in our altitude podcast as well with those guys in terms of, as the medic, you're often the person who has to deal with the consequences if the planning wasn't great. So we kind of brushed over earlier the issues around skin and the impact that the jungle environment can have on skin, and Matt is particularly keen to share his thoughts on this subject, I think.
Only because it's of huge clinical relevance and not a personal clinical interest of my own. But from going from to heat to feet, and conveniently it rhymes. So heat and the environment is so damp that people in this environment, you wear jungle boots, which have holes in to let the water come out. Because you will be walking through water. You are wet. Your socks are wet. Your feet are wet all the time. So you have wet feet. So the ability to dry your feet out at the end of the day, and good foot admin, as they would call it in the military, and put fungated talc on your feet, and that sort of really looking after your feet and blisters and all that sort of good foot management is absolutely key, because you're going to degrade whatever activity the group are doing if people just can't walk anymore because their feet are in such poor state. And it may well be that if you're doing a trekking thing, people it's new boots for them, and they've not really tested them out in that environment, and they're unfamiliar footwear, and they're going to cause hot spots and rubs and blisters, and you're going to really struggle to get blisters to heal. And any skin break is at risk of infection in that environment, because it's generally a dirty environment, dirty water in your boots. So I think looking after feet is common, and we see quite a lot of pitted keratitis, which is a sort of characteristic thing where it's a bacterial infection, and you see lots of sort of punctate lesions in the soles of the skin, and your feet really smell. And it's sort of it's trench foot type stuff, really, because you just can't dry out your feet. So foot admin, talc, socks it sounds mundane, but in terms of keeping the job going and keeping people on the task, the trek, the exercise, the expedition, it's vital, really.
Yeah, I would agree with Matt, actually. So we were in Fiji in 2019, and we saw a lot of pitted keratitis, and it was really around keeping your feet, like Matt was saying, dry, keeping them whenever there's a chance to rest, getting the socks off when you're sleeping or indeed resting. It's just getting the air around the feet, and early topical antibiotics if necessary, if it's starting to go down that way. But the foot admin is absolutely key, because it can be the absolute rate limiting step to the rest of the trip. And so it is prevailing bacterial infection. But you've also got to be aware of fungal infections, because those can take hold. But it really is it's giving your feet the best chance by every time you stop, just airing them, making sure you've got as many clean socks as possible. And the real concept as well is having wet kit in the day when you're hiking or tramping or racing, and it's dry kit at night. So you're always stepping into dry kit when you're sleeping. So you're not in your wet kit when you're in your basher or in your hammock or tent, that you've got a dry kit to step into, just to try and sort of stave off the bacterial infections.
Absolutely, I think it's boot and sock free or shoe free time. Essentially, I say let your feet air, and certainly a part of my daily routine is at the end of the working day, you go and have your wash in the Jungle River, and then just sit with my feet dried and talked, and let them sort of try and recover a little. People take tubs of talc, or what's quite common as well is take a quite robust polythene bag with talc in it, and you put your foot in the bag, give it a good shake. It works quite well, so you're not dropping talc everywhere. But if you've got a sort of an evening routine, bearing in mind it's very dark in the jungle and you can't do much when it does go dark, but if you are moving around, flip-flops probably aren't ideal to walk around the jungle. There's far too many things will come and bite you, so you end up having to wear some sort of enclosed footwear again, just to do your cooking, do whatever you're doing in the evening. So getting that air time and sort of sock free time for your feet is essential. Another top tip really is if people have got pitted keratitis, if you can manage, if you've got the wherewithal to do it, and you can rustle up some sort of bowl, and you can make bowls out of a curled up sand splint and a bit of water and a polythene in the middle to make yourself a makeshift bowl, a bit of betadine, only a few drops, and soak your feet in betadine water, or potassium permanganate crystals. You can still buy those, just to sort of try and disinfect your feet, and do that twice a day, and lots of medicated talc. And you can turn it around quite quickly, but you're always going to fight the tide on something like this in the jungle environment. Much easier when you've recovered out back to civilization, air conditioning. But it is a common problem, as Eoin rightly says. It just disables people if you can't walk, literally.
And I think you get that can
And
drill into
I'm just
Trigo.
listening to that and thinking, the evening stream wash. Are you going to catch any bugs in there, any leeches and that kind of stuff?
I was going to say, there's not a huge amount in the water that's going to cause you any problems. There are leeches there, and people do have a bit of a panic. You know, they as Matt was about to say, they do get absolutely everywhere. My son had one in his belly button in Brunei, but I picked one off someone's conjunctiva before. They had an utter panic attack first thing in the morning when a leech had attached itself to their globe. But they get in, they absolutely get everywhere. They are pervasive little monsters. But otherwise, in the water, there's very little that's going to cause you any problems. There was a spectacular reticulated python at the washdown point that we used at the last camp, which was huge. There was no way I was getting in that water with that monster in there. It must have been about 20 foot long. Until the I-band chopped it up.
There's a big panic about leeches, and I know when I get them, I squeal like a girl and scratch them off the fingernail and do all the bad things. But they are common, and I think it's some of education for the group and showing them what leeches are and the correct way to manage that and not to panic. And actually, these are the more acceptable ways of taking them off, which creates less bleeding. But inevitably, just everyone admit that you're highly likely all of us are going to get a few leeches on us during the course of whatever we're doing here. And let's try and not panic when we do, and help each other out and look at each other, because they're often you're climbing out of a stream and they're on the back of your leg and you can't see it yourself. So it is a bit of teamwork and getting them off each other and sort of familiarization with them really. And actually, they're not a huge problem if correctly managed, although they do clearly leave a wound, which in that environment is at risk of infection, so does need a bit of a clean. I think you can still get little betadine pots that are like nail varnish. And you can sit down at the end of the day and almost clean yourself up fine on your wounds and give them a blob of betadine or spray a betadine spray to try and prevent open wounds getting infected. But so leeches are fun, and there are other forms. When you do take that end of day dip in the stream, there's jungle crocodiles as well, also turtles and fish and all sorts of pleasant things. But quite a few things there to bite you. Don't go swimming on your own.
Wow. I'm excited at the prospect of a jungle expedition already. So thanks, gents. That's been really interesting to hear about all the different challenges that this type of expedition might present to us as a medic. Can I ask you a bit about, how do you plan for these events? How do you prepare? And what sort of would your top tips be? What have you learned from your experiences? I think we're going to go to Eoin for this one.
Yeah, thanks, Claire. So the old adage of sort of if you're going to chop a tree down, take 4 hours to sharpen the axe is true. It really is all in the preparation. So a couple of things I've learned really from the planning phase is just make sure that the actual CASEVAC plan works. So just that you have a plan A and plan B, so you prepare for failure of plan A. That you know, as to Matt's point before around, if you can't get a helicopter in to a triple canopy location, that's you're aware of that. So you've got to make sure you know what will work and what won't. You've got to make sure that the numbers you're going to use, the emergency numbers, actually have someone on the other end of the phone. So call the numbers prior to when you actually need them. Be prepared for comms failures. So 2 is 1 and 1 is none. Have a second comms device ready for use. Be mindful that you're actually at some point going to hand over to the indigenous medical provider. So actually, if you don't speak Spanish or if you don't speak Portuguese or someone in your group does, because actually when you come to point of handover or integration to the indigenous medical services, you're going to need to be able to communicate. So just think through those points as well. Just know as well from a situational awareness perspective that a lot of these things, as Matt was saying earlier, happen either in the darkness or indeed probably quite a reasonable amount away from base camp. So having a predefined plan of where the temporary stretcher is, which comms device you're going to use, making sure that the numbers work, making sure that you know who in your party will potentially CASEVAC the patient, from experience from previous Casevacs 10, 15 years ago, I've had a number actually within the Costa Rican jungle and in the jungle in Honduras. You need more people than you think you do. We took 4 people with us in Honduras 15 years ago when we had to Casevac someone with a complex comminuted fracture of his tib fib. We took 4 people with us, and it wasn't enough. As Matt was saying before, and Sean was saying, these environments are absolutely exhausting with almost 100% humidity. And actually, one of the team went down with heat illness as a consequence of a 6-hour Casevac back to base camp. So carrying someone for 6 hours is absolutely exhausting. You can lose situation awareness. From a rescuer's perspective, you can get the amygdala hijack, so you forget to drink or take rests. So it really can be a massive challenge. So it really is. Take more people than you think you'll need. Be aware of the systems and processes that you're going to use. Test them before you use them. So ring the numbers, tell people, find out, make sure that the chain of command or indeed of linkage works well, and just be prepared for worst case scenario. So when it rains in a jungle environment, the terrain gets incrementally more difficult to manage. So just be prepared for that. Be prepared that there is going to be a more dangerous time to operate in the jungle, and that's often in darkness, because you can't see the snakes, you can't see the tarantulas, you can't see the things that bite or that sting. So just brief the team, and also just be prepared for the worst case scenario. So it really is about that prior preparation, and also knowing where your kit is, knowing where your EpiPen is, knowing how much adrenaline you've got, making sure that the whole team know where the emergency kit and the emergency medication is. So having that situational awareness amongst the team, having a good brief before you get into the jungle environment. Look, guys, this is where we're going. This is going to be the rate limiting steps. You were actually going to travel a lot less further on the map than you think we will, because the terrain, although it might look fine, is absolutely undulating. And if it rains, we know it's going to become incrementally more difficult. So it's having that situation awareness, it's testing your systems, and it's being prepared for the worst case scenario.
I would completely agree. A movement on foot in the jungle on a good day on your own is tricky. You look at those maps of the jungle, and they're just full of contours and a single flat piece of ground. It's very difficult to walk. So if you've got a stretcher casualty, that is an absolute epic. And I don't know how far you went in that 6-hour Casevac, Eoin, but I bet it probably was only a couple of K. It is just enormously difficult and manpower resource. And remember, all snake bites are technically a stretcher case. So it's not an easy option at all, carrying someone in a stretcher around the jungle environment, and people will fall and injure themselves whilst being a stretcher bearer. So not something to do that I would relish doing. And when we have had to do it, to just Casevac someone from A to B, maybe to get them to a winch hole, you remember that.
What do you do for analgesia for those patients?
It's really tricky, actually. It's a great question, Claire. So a really useful adjunct I've used, and I'd be interested to hear what Matt thinks, but is Penthrox. So methoxyfluorine is a lovely, nimble drug in these environments. So Penthrox is a little green whistle. You can get people to sort of sub-anesthetic doses if they take the Penthrox correctly. And you can actually even put your finger over the hole and occlude the hole and double the strength. It's quick onset, quick offset. But the problem with extended Casevacs is the sort of longevity of pain management, really. So it's having probably multiple modalities which are going to last over time. So it wouldn't just be reliant on one modality like Penthrox. It might be reliant just oral meds, supplemented, sort of maybe paracetamol, ibuprofen, supplemented with Penthrox. If you have to go down the IV route, then I'd be a lot more careful, because your access to monitoring is very limited. But it's a multimodal approach. It's a sparing approach, especially if it's you're talking 6 to 8 to 10 hours down the line. You've got to be quite sparing and think ahead a lot more.
I agree, and I guess the fluffy GP in me would say it's the answer to all pain questions is always the 3 Ps, isn't it? It's the pharmacological, which Owen's covered well, then the psychological, and the physical. So you tell someone this is going to be difficult, this is going to hurt, and you try and encourage them to do it as you're banging them around with their broken limb on the stretcher. So there is a psychological element, and then it's that physical element of it's splintage, your Kendrick splint or whatever you've got. I carry plaster of Paris, a few good old fashioned plaster, a few rolls of plaster, and a bit of soft band to go underneath it. And I've managed many an extremity fracture and an ankle, and actually put a plaster on in the jungle to stop the physical movement. So the 3 Ps is always a good answer. And I agree with them. Lots of pharmacological options, as many as you can carry, really. But again, you are carrying your own kit, and you remember, as the medic, you're carrying your personal kit, your own survival clothes, whatever, plus the med pack. So you are likely to be quite lightly scaled in what you are able to take. So analgesia is we could probably have a whole session on that alone.
Yeah, we probably could.
Let's do
We'll come back to that one. What about nerve blocks? No, perhaps that's a bit technical.
I think, I guess it depends on the level of the clinician, and consciousness is going to a mixed audience. If it's in your skill set, absolutely. And femoral nerve blocks, you're fantastically effective. And actually, once you've done a few, are really quite simple. In the bigger scheme of things, is something that could be done. But I guess it depends on the skill set of the individual, and it's probably not something you'd ever be wanting to do for the first time in that environment. But it's certainly an option.
For sure. Cool. Thank you so much. That's really, really interesting to think about the challenges. It's a pretty awe-inspiring feat to think that anybody ever manages to go after we've sat here and talked about this for a bit.
I think the other CASEVAC angle is really if you are having a helicopter and you've got a helicopter CASEVAC, so there are numerous issues. If you fly over the jungle, you quite quickly see you can't land anywhere, or very, very few places. There may be a few HLSs that have been pre-established, but it's not going to be where you want it, which means winching, which is a tricky old thing. So to start with, the helicopter's got to find you. And you can give them a GPS if you've got GPS, and I suggest you have 2 or 3 GPS, and GPS won't always work through the thickness of the jungle canopy, so you might have to get someone into a clearing to get a really good fix on where you are. But actually how that pilot finds you when they're just flying over what looks like lots of broccoli underneath you, where's the casualty? So we certainly in the military have these air marker balloons, which is essentially like a party balloon, a small bottle of helium in it, and it's blue and pink on a long string, and you find the biggest clearing you've got and you put your balloon up. And when the pilots are coming in, certainly daytime, obviously, you can see, because it stands a bright sort of metallic pink balloon stands out in that environment, and the pilot can sort of like hone in you quite quickly. It can be difficult, and to get they all being well, that someone will winch down to you, but you really need quite a big space to get them in. You need quite a big winch hole. And there are some natural clearings. Hopefully, there's one close to you. But cutting a winch hole, people sort of often talk about quite glibly. Oh, we just cut ourselves a winch hole. Again, that's half a day's work for a team of people. It's an epic job, and you need chainsaws to do it with any degree of speed. So sometimes certainly where we tend in the military, we tend to know where we're working, so we'll have pre-positioned, pre-cut winch holes, which are identified where the pilots know, sort of they're numbered or lettered. So get a winch hole A, and we can meet them there. But cutting one on your own is a big thing. They'll tend to drop a basket down, you load the casualty up, package them, and go up. But when they go up, they spin, and it's not at all uncommon to bounce off the trees on the way up. And we've certainly had, there's been reported cases of people getting injured, particularly head injuries if they weren't correctly packaged from a branch on the way back up to the helicopter. And a final one to perhaps think about is deadfall. So deadfall is when high up in the jungle canopy, a branch has fallen or a tree has fallen and is rotten and is sat there poised, ready to fall on you. And some of these logs are absolutely enormous. And if all of a sudden you bring a helicopter in, that'll dislodge everything in the canopy above and come crashing down. And there are, it's quite, there's lots of reported cases of deaths and significant injury from deadfall triggered by helicopters. So, yeah, I think as I said at the start, CASEVAC is not something to be undertaken lightly nor wantonly. And you really need to be careful about when you call a helicopter in, because you could do more harm than good. So clearly, if you need to CASEVAC someone, they need to go, but it needs to be thought about and planned and certainly rehearsed, as Eoin said.
Thanks, Matt. It's a really useful and thought-provoking summary of the challenges that can be faced.
Can I just mention one or two other things that sort of link into that, really? One is the comms, and I mentioned comms. It can be difficult to communicate. Mobile phones aren't going to work. So it's all satellite comms. And again, you sometimes struggle to get a signal bouncing through the tree canopy because it's so thick. So sending someone out, so you can end up having, comms difficulties just getting your sat phones to work. And as I said before, you always want backup comms and backup plans, but it's not as straightforward as you think just to use the sat comms in that environment. And I think the other one is navigation. Jungle navigation is an expert skill. It is there's very few reference points. It's incredibly easy to get disorientated. A good friend of mine wandered off, actually saw a butterfly, big roughy toughy soldier, beautiful butterfly, chased it for sort of 10, 15 meters, trying to get a picture of it, turned around, realized it very quickly got very lost. All trees look the same, and he was disorientated and lost for quite a significant time until by luck, he managed to get himself back. So it's a lot of it. It's the mapping is often very poor. So you really want someone who is an expert in jungle navigation to be guiding you through the jungle. A lot of it is about pacing. So you can calculate how far you've walked, because it's deceptive, and your pacing changes uphill and downhill. There's a tendency to walk along ridge lines because it's easier. But I say they're often poorly mapped, and it's a challenge, and it's a lot of strong compass work as well. So not something for the amateur to go in and think they can navigate around the jungle. It's very difficult, even with GPS.
Yeah, I would agree with Matt, actually. And I'd say that, VHF radios fail a lot of times. So because any big land masses, especially as the terrain's undulating, will stop VHF radios transmitting to each other. But as we were saying before, you have to plan for that. So, and plan for the fact that you may not get sat phone in triple canopy, as Matt was saying. So it's tricky. It really is tricky. And, you're down to your plan C or your plan D, which might be an InReach by Garmin or another kind of device, which is sort of a sat nav GPS system, and so you really have to have multiple modalities, because I think some of the take homes, as Matt was saying, is everything fails in the jungle, and it is the ultimate testing ground. It's the ultimate testing ground of your situation awareness, of your map reading skills, of your ability to communicate, of your preparedness, so your primary and your secondary and tertiary plan. And also indeed your clinical acumen, because everything is impaired. You've got less access to monitoring, less access to diagnostics. Things get masked. The prevailing sort of heat illness gets mixed in with the endemic disease. So you really have to, it really does test everything about you, both from a clinical perspective, but just also from a personal perspective. Your own, as we were just saying, your own personal admin. And there's nothing worse or more embarrassing than coming down with an illness yourself because of poor personal admin in front of a team when you were responsible for the healthcare of the team. So good admin around your foot care, around your hydration, around your solar radiation, so not getting burnt skin, making sure that you're not coming down with any of these diseases, so that you can take care of other people.
It sounds like we've painted quite a negative picture of all this, really. It's not the intent. It's actually one of the fantastic, beautiful, exhilarating, challenging, and wonderful places to be for those that like it. And it's not for everyone. It's actually quite claustrophobic, and it's very noisy, particularly at night. So some people just don't get on with it. But I think those that do, and I it's recreational. I love being back in the jungle. So I would encourage our listenership to not be too disheartened by what we've said, but take it as wise words of planning, but still take the opportunity to go. But I think my one top tip, and I guess take home, would be it's not being in charge of medically in charge of a jungle expedition. Having never done it before is not a thing to do. I would always recommend go with someone else who's experienced and learn from them, and then before you're in charge yourself. So don't be naive to the jungle on your first time that you're the sole medic there, because there is a lot to learn, and by the time you do trip 2, you realised how much you learn on trip 1.
Oh, thanks both. That's a really lovely wrap up there. And what I'll do is I'll get you to send me some of your holiday snaps, so we can share those on our blog post if we may, because I'd certainly love to see the attractive bits of the jungle as well as hear about the dangerous bits. But you've done a lovely job of sharing your thoughts with us. So thank you so much for your time. It's much appreciated.
Absolute pleasure. Happy to help.
Thanks.
Pass
Thanks,
on
Claire.
Thank you.